Good afternoon, I'm Ezra Klein, and welcome to a revived edition of WonkTalk. I'm here with Avik of Forbes and of the Apothecary and of the Manhattan Institute. Yes, the Manhattan Institute. And Avik, as many folks out in WonkTalkia will know, has been writing a lot of stuff on Obamacare. He's a conservative-leaning healthcare expert. We've been talking a lot about rate shock and premiums. Him and I have been going back and forth, and we thought it would be fun to sit down and actually talk it out as wonks on WonkTalk. So thank you for being here today.
My pleasure, Ezra.
All right, so here's where I wanted to begin. Because this is a video and I want more than 2 people to watch it, you and I going back and forth on like what literally are rates is all on the internet now.
Yeah.
And so I want to step back for a moment because back in the day, before the Affordable Care Act completely changed healthcare debating everywhere, you and I used to talk a lot about the Swiss system, right? You like Switzerland. You wrote even just a year ago they have the best system in the world. And they have this exact thing that you're worried about here. They have community rating, which means everybody gets charged the same price. They have guaranteed issue, which means you can't throw people out. So if we did Switzerland here, we'd have rate shock.
Right.
And if we did the John McCain plan or the Mitt Romney plan, where you take away the healthcare deduction for employers, the people who used to be getting really lavish employer-funded care, they would have rate shock. They would be paying more. And if we block granted Medicaid, you'd have people there who used to be getting Medicaid, now they're not because we cut it by $700 billion. They're having some kind of rate shock. And so the thing I wanted to ask sort of as a broad question, in any kind of significant reform, there will be winners and there will be losers. There will be people who pay less and people who pay a bit more. How fundamentally do you think about those trade-offs? Because I think that's been something that's been essentially forgotten in this conversation. Like, what is the basic architecture of how we should understand these trade-offs in healthcare reform?
Yeah, so I think there are really 3 questions that you have to ask and answer when it comes to that discussion. The first is, it's a matter of degree. How much do the winners win versus how much do the losers lose when you reshuffle that deck a little bit with any health reform? The second is, from a policy standpoint, what you achieve by reshuffling the winners and losers. Is it a good policy outcome, both morally and just from an economic standpoint? Does it work? And then the third thing is maybe less important, which is the politics of it, which is what we end up talking about a lot. But when it comes to those 3 things, if you just to go back to what you said about Switzerland, so when I wrote about the Swiss system, I guess 2-3 years ago now, I criticized that element of the law. So I said, look, if we were to replicate the Swiss model here, what I like about it is that it's a sliding scale of subsidies, that people have a broad range of choices about plans. I wish that there was a broader range of plans. I wish there were more high deductible options. I wish that the benefits weren't so aggressively mandated. But otherwise, I like that general system where we subsidize the poor, we partially subsidize the middle class, we don't subsidize the wealthy, and that we give people those choices in their private sector options. So in that sense, you're right that the Swiss system is like what the ACA exchanges are, but the things that I'm objecting to about this ACA are the same things I was objecting to about the Swiss system.
So I'll buy that. And in 2011, you did say that. I don't remember this being a big issue back in sort of the pre-Obama, but it's fair enough to say that these things focus the mind. But I actually think I do want to focus on this because I do think it's important. So what we talk about when we talk about rate shock, and it's worth saying here that a lot of the details are contested in different directions, but I think this will be a fair summary, and you can tell me if you think it isn't. When we talk about rate shock, when you talk about it, what we're saying here is if you look at younger, healthier people, before talking about subsidies in this case, who are in the individual market now, who are buying a very cheap plan now, because typically you've been comparing the cheapest plan in ehealthinsurance.com to what we're dealing with. If you look at what they're paying and you assume they don't get subsidies, they might end up paying more. Or in many cases, frankly, let's say they will end up paying more. And for 2 reasons, right? Because I think we should be clear on mechanism. One reason they'll end up paying more is because we're bringing in older and sicker people into the market. And essentially, the cost of your premium is the average expected cost of the people in the market plus whatever insurers are charging for administration and profit. The second major thing is that there are benefit differences in what the Affordable Care Act is willing to say is insurance and what we say is insurance now. So a lot of those cheaper plans have incredibly high deductibles. I mean, there are plans out there with $10,000, $15,000. The amount of out-of-pocket costs can often be in the 5 digits as well. This is something I think that's actually important. The out-of-pocket cost is often not included in a lot of these analyses of what we talk about when we talk about rate shock. So there are 2 things basically the Affordable Care Act is doing for the young that will raise costs for them. One is bringing in older, sicker folks to the market, and the other is mandating a more generous benefits package than you find at the very low end of the individual market. And then on the other side of that, the big player that also comes in here, 2 things: the subsidies, which is $950 billion in this market over the next 10 years, and then the individual mandate, which is a penalty if you don't buy healthcare insurance. And the question of rate shock for these young people is how does all of that sort of stew up and interact? How does the fact that they're maybe paying more for their insurance interact with the fact they're generally fairly poor, so they get a lot of subsidies, interact with the individual mandate, and how does that end up making the entire exchange work? Because you need these young and healthy people in there if the exchanges are going to have a reasonable risk pool and low enough premiums. Is that
I'd say that's generally right. There's a couple
Yeah.
things just for the sake of completeness
Yeah.
that I would add. So, for example, there's a mandated number of types of services that are covered. It's not just the co-pays and the deductibles,
Right, yes.
but also the types
The
of
essential
benefits.
benefits
The
are
essential
called.
benefits. There's the premium tax, which gets passed down to consumers in the form of higher premiums. So there are a couple of things on the margins that maybe add, say, another 10% to the increased price. But the biggest ones are what you might say changes to the risk pool. So covering everyone's pre-existing conditions and having the young subsidize the old. That's the risk pool portion. And then there's the, shall we call it, the increased benefit, financial benefit, the increased actuarial value, which is the lower co-pays, the lower deductibles, et
And
cetera.
so when I hear that, I think great. Right, so because I think it's actually important. What we're talking about for this group of people, and it's very important to say this is a small group of people actually. It's not nobody, but we're talking about the exchanges we expect to have between 2 and 8% of the population in the first 10 years. The young people on the exchanges are a fraction of that. I mean, we're dealing with single digits. It's not, I get my healthcare through the Washington Post. This isn't about me.
I will just interject that
Yeah.
it's not just the people who will be on the exchange, it's anyone who interacts with the individual market. So if you're trying to buy insurance on the individual market outside the exchange, all these regulations still apply to you. If you're uninsured and therefore you're not getting...
But not these exact premium shock, right? I mean, that's a slightly different calculation. But
Yeah.
but yeah, putting that aside, because
yeah.
I don't think
Yeah,
it matters for this. What I think is interesting here is what we're talking about is a fairly mechanistic process, right? What we're saying here is that there are two things going on the cost increase side that you can either like or you don't like. We're not saying basically the government is going to take a bunch of the money in taxes. We're not saying it's going to be lost in waste. Maybe people believe that. But what we're saying simply is that we are going to see some people paying more in order to reframe this a little bit, in order to have older, sicker folks be able to come in and pay sort of more reasonable premiums, and in order to have insurance packages that we think work better as insurance, and we sort of here being the sort of the societal affirmation encoded in the governmental process. I recognize that not everybody agrees with that.
Yeah.
But so that to me, I think actually gets at this a little bit better, because I actually think that's fine, right? I mean, so when I hear that, I think this is exactly what we want to do. I mean, there are a lot of people in these markets who are getting either they're not allowed to buy for the price they need to buy it for, and there are a lot of people who are simply not allowed to buy it at any price. I mean, we've seen both of these things in the individual market. And you know, we've seen a lot of insurance that doesn't end up covering what people need covered. I mean, the horror stories of somebody who thought they had something and they actually get in a car, they had no idea what the out-of-pocket cost could really be, or it turned out that their pre-existing condition was not actually covered in it, and anything related to that was outlawed under the plan. This to me sounds like rationalizing the market in ways that are positive. And obviously, if you didn't have the subsidies coming in, the affordability wouldn't be good enough. But that just seems to me to be a question of whether or not the subsidies are sufficient. Tell me why you disagree.
Yeah, so I agree in part and I disagree in part. So I think some of those elements that you described in terms of rationalizing the market are good things. So I don't have a problem with standardizing benefits insofar as it means that some people don't get caught in the fine print, the kinds of things you were talking about. I don't really have a problem with guaranteed issue, so long as there's some sort of mechanism that'll make sure that everyone stays in the pool. Guaranteed issue is fine. I have a problem with a couple of things. One, I have a problem with age-based community rating, so the young subsidizing the old. To me, that makes no sense. You take a bunch of people who are just entering the workforce, who have no savings, who are taking entry-level jobs, who don't have a lot of money, and you're asking them to subsidize the people who've had their whole lives to save for their health insurance, who are at senior-level positions, who've had jobs for a long time. So that seems to me, from an equity standpoint, unfair.
But can I interject one thing?
Yeah.
That's not who we're talking about here, though. I mean, when we talk about the people in the exchanges, in the individual market, we're not talking about the C-class. We're not talking about the folks on the north wall over here. Those people are getting employer-based insurance, are not getting subsidies. They're typically not
Less
in
so,
exchanges.
though, right?
Sure. I'm not saying you don't have. I mean, the thing that accounts for that, of course, is the young get more subsidies than the old because they are poor. But a lot of the folks we're talking about, I just feel like that the way you describe that wipes out a very large group of people in the 45, 55, 65-year-old range. I mean, my mother takes care of children for a living. She's a nanny, and she's 64, so she'll be on Medicare soon. She's had a history of some health problems. She gets individual market insurance. It is her single largest expense. It is huge, and it is a huge burden on her. So I just think that it's not the case that everybody who's older in this market is doing great, nor the case that everybody who's younger in the market is doing poorly. I mean, there's a lot of insurances, the young subsidizing the old, the healthy subsidizing the sick, and the rich subsidizing the poor. And we do that because we assume that one day we will be old, and one day we will be sick, and one day, we could, if we're doing better now, could be poor. And that's the idea of it.
So let me push back on that.
Yeah.
So the thing is, it's not exactly right that young people, because they're low income, will do better under the exchanges, because if you're a single member household, the FPL, the federal poverty level, and that keys off the subsidies is a much lower number. So if you're a 25-year-old, or let's say you're not getting insurance from your parents, and you're just a single person with no children, the FPL level, 100% of FPL is like $11,000.
Let's just say poverty line.
Poverty line.
To be good
poverty
to
line.
To be
Right.
good to our listeners.
Yeah, exactly. Whereas if you're an average 40-year-old or 50-year-old, where maybe you're married, you have kids, or there's just more people in your household, those numbers go up. So that's one thing. So I have no problem subsidizing people who are low income. I think the problem is that when you force younger people to subsidize older people independent of income, that's what creates a lot of problems.
But it's not independent. I mean, this is just, I think, the thing I want to focus on, because I do think it's important, right? The subsidies, the young people would be the group that benefits from them the most, because they are, on average, poorer than everyone else. But the other thing that has not been, this is something the Urban Institute persuaded me of, but it's not been well taken into account, I think, in some of the writing here. The way that the bill works is not just to subsidize people, right? It also has out-of-pocket maximums in terms of what you can pay in premiums and out-of-pocket costs in a year. And if you're under 400% of the poverty line, these trigger for you. So you can't pay, I think, at the maximum more than 9% of your income in a year. And underneath that goes, 9.5. Underneath that, it goes much lower. So if you're making 200% of the poverty line and you're a single young male adult, you can't pay more than, I don't have the table exactly in my head, but it's 4.5%, 5%. So you're dealing with an actually quite subsidized kind of insurance, and not just through the direct subsidy, but through what can eventually be asked of you. And I think that's important, because we are saying we are going to cap how much you subsidize. It's not just if you're young, you're going to be giving a huge subsidy to the old. It's that if you're young and you're having trouble, we're going to help you too.
Yeah, so again, the devil's in the details. So if you actually look at the way it works, the way the scale of the subsidies work, you really get a subsidy if you're under about 250% of the poverty line. If you're above 250% of the poverty line to 400, where it ends, it's a partial subsidy, but it doesn't really insulate you from the big increase in rates. So
it gets smaller above that,
so the real people, it goes like this. It's like a sigmoidal curve. So you are protected if you're at the low end of that scale. If you're at the high end of that subsidy range, you're not as protected. So the American Academy of Actuaries magazine, Contingencies, did a big report on this a couple months back, where they calculate, okay, for people who are in their 20s, what percentage will still face increased premiums if there's an overall average increase in premiums by 10%. And they found that 80% of 20-somethings will pay more in premiums, even inclusive of subsidies. I think with 30-somethings, it was like 35%. And that was only with a 10% increase in the average premium rate. And that's because they only looked at community rating. They didn't look at all these other factors that we talked about. So I think actually there are going to be a lot of people who pay more. And the challenge is, you can make the case that, well, people should have these richer benefit plans, and they will get old eventually. There's two challenges with that. The first is on the people will get old eventually part. Yes, people will get old eventually, but today, what is their economic incentive? Today, if their rates are going to go up a lot, their economic incentive is to drop out of the market and pay the fine, right? So, some people may not. Some people may still say, well, I'm just going to pay, I won't pay the fine, I'll adhere to the law, and I'll buy insurance. But a lot of people may not. In Massachusetts, that wasn't the experience, but Massachusetts is a very different insurance market. The other problem in terms of the benefits is, take restaurants. So there's a restaurant you and I like across the street, the Federalist, right? So they serve like farm-to-table food from local farms, organic food, and we may all think that it's great that people eat organic food, but if we mandate that, we're making the cost of food more expensive.
Well, let's leave the. Are you talking about now the employer mandate in there?
I'm talking about the mandates that make the insurance product richer.
Sorry, I just
right?
wanted to be clear.
Yeah, so because you're arguing it's good that people have a richer insurance product.
So just to be clear, you're saying that if the Federalist, if everybody had to do organic food, costs would go up for everybody. So the question, and here you're saying everybody has to cover, say, maternity benefits, so costs go up for everybody.
So the costs go up more, but it's not clear that the benefit is worth it. So, I think your argument, and the argument of a lot of people on the left, is more insurance is better. Less cost sharing is better.
Up to a point.
Up to a point.
Right?
But in general, there's a bias towards less cost sharing.
Well,
lower
that's actually
deductibles.
that's not my bias, and so I think there are two things here, right? One is the cost sharing. If you're talking about somebody who is not getting a protection at this point, right? You're talking about cost sharing up to about $6,500 out of pocket for an
Right.
individual. Now, maybe you think that that isn't enough. Right, that's a lot of cost sharing in a year for most
Yeah,
people.
yeah.
I mean, that would
Yeah.
that would hurt,
Yeah.
and particularly if you're talking about the kind of people on the individual market. So I always kind of want to hear what the answer is here,
Yeah.
right? Do you want it to be 10,000? Is it 15,000? What is the level of deductible at which we said, okay, these people are going to feel the pain when they want to go to the doctor? And then the other piece of that, which I do think matters here a bit, when we talk about the age rating, right, and when we talk about whether or not the young should subsidize the old and whether or not that's a fair thing to do, I do think it's worth saying that it's not clear how much you would, sorry, that's actually a separate point. When you talk about whether or not they will stay in the market, whether or not they will drop out and use the individual mandate, which I totally agree with you, right? On a sheer economic incentive argument, that might be the best deal in the bill. Just pay the individual mandate, wait till you get sick, buy insurance for whatever it'll cost. It's a great deal. But we have to, I think, admit here that we haven't seen that happen anywhere. Now, in theory, that could happen in Sweden, or Switzerland, I'm sorry, it doesn't happen there. It could have happened in Massachusetts, it didn't happen there. So we need to come up with something that is different about America, such that all these kids are going to be dropping out. Now, maybe what's different is you. Right? Maybe what's different is you and folks in the Republican Party and a sort of general atmosphere of this is a terrible bill and is the right thing to do, a kind of almost civil disobedience-like approach to it, and just pay the mandate and try to game the bill, in which case I would just say the answer is you make the mandate harder to game and you ratchet it up and ratchet it up. But maybe you can't do that politically, so you create a kind of gridlock that ruins the bill. But it is worth saying that in the past, it just isn't clear. There's no evidence of young people just saying that they don't value insurance that much, they don't want it. I mean, when you see take-up rates of young people and employers, they take up employer-based healthcare insurance, pay for it at about the same level as older workers. It's above 70%. So I think it's a economically rational point you make there, and it's completely true. If young people all decide to pay the individual mandate, the exchanges will completely collapse in on themselves. But we are working here the way this bill was designed. We are sort of working here with, I think, the best understanding we have of how young people work in the insurance market. If that proves totally wrong, if the world is a different world than the world sort of that all the models thought we were in, that would be bad. But we don't have reason at the moment to think it is totally wrong.
Yeah, so I'd say a couple of things in response to that. So you're right that in Massachusetts and Switzerland, that is not the experience we have. People do adhere to the mandate, people do buy insurance. A couple of points that are counterexamples. So in the states that have had guaranteed issue and community rating, so requiring people to cover insurers to cover pre-existing conditions and for the young to subsidize the old. So it's like New York State, Washington State, New Jersey, Kentucky had it for a while. In all the states that had it without an individual mandate, the insurance market fell apart.
And without subsidies.
Right, and without
but to
subsidies.
have without a mandate and subsidies
Right.
is just a completely different ballgame.
So that's an important point to tease out. So how much of the adherence to all these rules is driven by the subsidies versus the mandate, right? So if it's driven really by the subsidies and not by the mandate, then for the people who are going to face increased prices despite the subsidies, there's still the rational economic decision to do it. So I think it may be partially that the law is more controversial in, say, a Texas, but in a California, which is a more democratic state, then we'll see where, because that's a state which has low insurance, individual market is relatively inexpensive today compared to, say, Massachusetts, where it was extremely expensive in pre-2006. We'll see if that increase in rates leads to different behavior or not. I fear that it may. It may not, though. But I think that we have to be aware that it's a possibility. And the reason why I oppose the young subsidizing the old and an unnecessary increase in the mandates for benefits is because I worry about adverse selection. It's not because I don't want people to have health care. I support the subsidies. I support guaranteed issue. What I worry about is that if you drive up the costs of health insurance for young and healthy people who have moderate to higher income, so $30,000, $40,000 a year, if those people drop out, and those are the people who are out of the market today, that's the uninsured population to a large degree today, if those people stay out of the market, then we continue to have structural problems with the insurance market.
So agreeing with that, let's tease that out though. So what we're saying here, and I think it's important to think of these markets a little bit like a balloon. You squeeze one part, premiums move in another part, right? I think we agree on that. So let's say that you do a 10-to-1 age band. So sorry, that's getting too wonky, I think, for this video. Let's say that you don't have this age rating. Let's say that you just allow insurers to charge age to age whatever they want.
Right, not health status, but age. So
Not,
like all 25-year-olds pay the same price, all 40-years pay the same price. Yeah.
What you're saying there is that 45-year-olds are simply going to pay more. You're not saying the whole market will be cheaper or better. You're saying that in order to give 25-year-olds a better deal, you're going to make 45 or 50-year-olds pay more.
It's a combination, right? Because you have to assume that there will be also adverse selection if you do community rating.
Right, but
so if there's less community rating, there's less adverse selection, more healthy people get into the pool.
And that's why, and to be fair, this is something they've thought about. It's why they actually allow the administration. It's why they allow the insurers to do a 3-to-1 rating, so you can charge a young person 3 times more in their modeling and equations and whatever else.
It's not 1-to-1. AARP wanted 2-to-1, and
exactly. So I mean, people have
instead.
tried to figure out what is the balance to strike. There was an interesting Urban paper on a 5-to-1, and they found they didn't think it would make much difference one way or the other for anybody's
6-to-1
costs.
is in an underwritten market. 6-to-1 is about the ratio
so
between an 18-year-old
so
and
this is
64-year-old.
this is to some degree a technical question we're asking here, and then we're asking a secondary question, which is what is more important to us, right? Like how much do we want to get these older people in? How much do we want to make it affordable for them? You could also bring down the age rating and bring up subsidies. There are different things you can do, but they are fundamentally technical questions. And one thing that I think is interesting here is we can solve any of these, right? I mean, when we talk about rate shock or we talk about the mandate, I mean, any of these things that go wrong, we can solve. My great fear about the Affordable Care Act is that, look, things are going to go wrong. Things are also going to go right, but things are going to go wrong. But you have a kind of an unusual sort of gridlock, I think, right now, in which you can't fix anything because Republicans won't fix anything, but you can't repeal it because Democrats won't repeal it. And so you have a law that when things do go wrong, if we decide maybe the age rating is perfect, but the mandate isn't where it needs to be, or maybe both of those work well, but you actually need a different particular composition of subsidies from the low end to the medium end. I don't understand how we are going to manage this law in the next 10 years if there's not a little bit more of a commitment among folks on the right to actually try to make the thing work. And now, one thing I respect about the work you've done on this is to say, okay, my fix for it is X. I think that we shouldn't have the kind of age rating we have in law, and we should do something different. But it does seem to me that we are entering a place where we've made a lot of technical judgments, we as a country. The technical judgments always will be a little bit off from reality. Some will be off in ways that don't matter, others will be off in ways that matter a lot. And for this bill or any bill to work, you need to be able to update it as reality comes in, right? As the facts of reality come in. And one of the things I worry about, and you would know this better than I do, is that there's just not a willingness right now on the Republican side to update as reality comes in. Right now, there's a fight over whether or not when a constituent calls a Republican congressman, a lot of Republicans are saying they won't help the constituent navigate the bill. They're just going to say this is the Obama administration's problem, call the White House. It's a really, I think, unfortunate approach to take.
Yeah, so I completely agree with you that my view and the view I've articulated since the election, if not before, is there are ways to make. I believe in exchanges. I believe in the general Swiss framework of subsidizing lower income people and standardizing the insurance product and protecting people with pre-existing conditions. So, and I think there's a way to do that. There's a way to modify the exchanges to make them work from my point of view. When that original piece I wrote about California entered the vortex and went viral and everyone got worked up about it, I think there was a danger of overreaction on both sides, right? So on the right, there might be the reaction that, well, this just shows that exchanges can't work, which is not, I don't agree with that. I think exchanges can work, and I wouldn't want people to take that lesson away that because the Obamacare exchanges might have these rate shock issues that Obamacare, that exchanges in general as a principle are a bad principle. And similarly on the left, I think some of the reaction was, well, you're using this problem to create a pretext for repeal, and I explicitly did not. I explicitly said, look, this isn't about repeal. This is about making modifications to the exchanges so that there isn't adverse selection. So from a political standpoint, you're right, that's still the fight today, and I think that will be the fight through 2014 because there is a view in the Republican Party that at this point, well, we lost the 2012 election, the law is going to get implemented, we're going to see what happens. If it fares badly, we want to be able to say, look, we told you that it wasn't going to work, and here, vote for us because we will have some sort of solution, though that solution has not been articulated to date. I think as we get into the presidential cycle again in 2016, it will be incumbent upon whoever the Republican nominee is to have some alternative. If it's repeal and replace, to have a replace. If it's not repeal, if it's something more like what I and Doug Holtz-Eakin have articulated, then it will have to be something like that, a major changes to the law that will address some of these issues that we've raised.
So that brings up, I think, a secondary point that I just want to go back to for a second, because there's a question of how do you make technical fixes, and then there's a question of how do you understand what is the insurance product, which is a somewhat more complicated, I think, philosophical question. So I think that in terms of the age thing, I think that a fair-minded viewer of this would kind of look at it and say, okay, we're just kind of gonna have to see if they've gotten the balance on this right? I mean, it might be the 3-to-1 is good enough, and I'm more sanguine about this than you are, but maybe you're right, and for whatever combination of reasons, young people don't come in, and then you'd want to begin figuring out how to change that. You could change it on the mandate side, you could change it on other sides, but that's a question that'll be judged from the risk pool, and I think everybody basically agrees that the bad outcome there is a bad outcome. Everybody agrees that if you don't have young people come in, you have a real problem. The other question, and this is a big part of what changes the premiums, and it's something that I think frustrates people about some of your writing on this, which is that it's not mentioned very clearly that people are often paying more because they're getting insurance that I think a lot of folks will consider better. Yeah. But it does get to this thing we were talking about a couple moments ago, right? What is insurance? What should it be? What should it have to cover? Particularly, what should it have to cover if the government is going to be subsidizing it? Yeah. So in the markets, you have a catastrophic plan for young people that only young people can get. And then you have these bronze plans, which are expected to cover, I'm doing this from memory now, 65%, I think, of somebody's expected cost in a year.
60 or 70. It's
beneath 70, okay. I'm pretty sure.
Right.
And the question that brings up, I think, is, well, okay, so for you, what do you think insurance should have to cover? I mean, when I really mean it, like, if $6,500 is not enough for somebody to have to pay in a year to be cost sensitive, what is enough?
Yeah.
Because they did make a decision, right? They could have gone for an extremely detailed insurance package, and they didn't. They left a lot of that to the states. A lot of people felt the federal government punted on defining what insurance means. All they really say now is you got to cover these sort of 11 large baskets of care, ambulatory care, maternity care, things like that. And you've got to sort of follow these limits on how much you actually cover of what the person needs. Where should those limits be set in your view? What is fair to do?
Yeah, it's a great question. I'm glad you asked that. So I think one of the reasons there was sort of maybe, as you said, people were frustrated that I didn't emphasize that component of that, well, the benefit is much richer, because I actually don't believe the benefit should be richer. I think that people are overinsured today, and that we could do a lot better with a system where there was catastrophic coverage and health savings accounts or some other form of account-based savings for routine expenses. That's what all other kinds of insurance are. Like when we buy car insurance, we don't expect our car insurance to pay for our wiper fluid or our gasoline, or let alone our fuzzy dice.
Although to be fair, I don't care if my car's leg hurts. but can I just sharpen this question just in one way? I think it is fair to say that we have two separate insurance problems in this country. We have a bunch of people who have too little insurance, and then a bunch of people who have too much.
Totally agree.
Right? So my question is a little bit, because I think we need to be clear always about who we're talking about. Are the people in this market, in the individual market, are the people buying these bronze plans or these low silver plans who can pay up to a $6,500 deductible, are they overinsured? And if so, in what way? Why do you think they're overinsured?
Great question. So
thank you.
So I think you're right that the bronze, purely from an actuarial value standpoint, the bronze plans are pretty close to a reasonable insurance product. The challenge there is, and Lonnie Chen and Phil Klein and some others have looked at this, if you actually look at plans in the individual market today in California, say, that are comparable to the bronze plan product, so they have the $6,500 deductible, they have comparable copays, et cetera. The bronze plans on the ACA exchanges are much more expensive because of all the other things, the benefit mandates, some of the risk pool changes, et cetera. So there's a middle ground, and again, it is the devil's in the details.
But what are you giving up? Because I want you to be specific about this, right? So what are you giving up what would you give up in the insurance package now? Let's put it that way.
So what I would want, if I were designing an exchange, what I would want is I would want guaranteed issue, and I would want I want to have more flexibility on insurance benefit design. So maybe lower actual, so I think whatever it is, it's 60, 70, 80 today, or whatever the actuarial value bands are, make it, say, 40, 60, 80.
Actuarial, just to define this for the viewers, is actuarial. When you say 65% actuarial, it means it will cover the 65% of your expected healthcare costs in the next year.
Yeah, exactly.
So when you average out the pool, that's just what and so for somebody who's way more healthcare costs, if it's good insurance, cover a lot more. For somebody with way less, it'll cover basically, but 60, that's what we say when we say actuarial.
It's basically a way of compiling all the out-of-pocket expenses between the premiums, the copays, the deductibles, et cetera. It's kind of a way of summarizing all that.
So in theory, if I have $100 in healthcare costs and my actuarial value of my insurance is 65%, they will pay $65 and I will pay $35. Yeah.
In the combination of all those
I just
factors.
wanted to define that.
Yeah, no, I'm glad you did. So I think having a little more flexibility around the actuarial value floor, so I think that's one thing you can do. So have something that's lower than what the bronze is.
How much lower?
Not that much lower. So like, maybe 10 or 15 or 20%.
So you're saying 55 or something?
Something like that,
okay.
Yeah. That would be one thing I would do. Again, I would ask people to pay the same rate if they're in the same age say, birth year. So 23-year-olds pay the same, 40-year-olds pay the same as each other. I think that helps address some of the adverse selection issues, but still make sure that people with pre-existing conditions and people with variations in health status do fine.
And what
Same
happens,
with gender. You can have equal gender rating. Things
and
like
what
that.
happens to people? So this is the other side of the balloon here, right? Because basically, I think if somebody read you, right, they would say you hate this goddamn bill. Like, you're not one of the people who's sort of a repeal dead ender on it, so to speak, but you're very negative on it. You think it's a bad bill. You would have liked to see it repealed. I mean, I think it's more that you've accommodated to the reality of it as opposed to you support it. And then you talk here, and it's like, well, the bronze plan is kind of almost where I want it to be. It's 5%, 10%, and maybe I'd like to see a slightly different approach to age rating, but that would obviously bring some other issues you'd have to deal with in terms of how do 55-year-olds get insurance. Maybe you subsidize them more. I don't know what you do there. But it doesn't sound that far. And this goes to something that I've always found is sort of fascinating about this bill. Back in the day when we talked about the Swiss system, this seemed, if we were talking about how do you take a first step towards it, something like this bill, like what Mitt Romney, a candidate you advised, although not when he was running for governor, did in Massachusetts, or what Senate Republicans proposed in the 90s, would have seemed like a good step. And I get having issues with this bill and wanting to sort of set the dials in different places from where it is. Frankly, I have a bunch of those issues myself. And in some ways, I'd probably go a little bit lower on the actuarial value as well. But it doesn't, when I talk to you here, the vehemence of it seems a little bit surprising, and the focus only on the folks who will pay more. It actually seems like you have a significant zone of agreement.
Yeah, so and we've talked about this in the past when the bill was being debated and over the last several years before the election, about this thing. Well, you like the Swiss system, so why are you opposed to this? Yeah. And one of the things that I've brought up is that if the ACA exchanges had not been just for the uninsured, but that we talked about migrating the Medicaid and Medicare population out of those exchanges. That's something that really would have excited a lot of conservatives. Now, I know that liberals disagree, so a lot of people on the left say, well, that deal could have been on the table, that was something like Wyden-Bennett or what have you, and Republicans just were nihilists and they would have rejected. That's not my reading of the historical record. I've read all the books, John McDonough's book and Paul Starr's, and that's not what I saw. What I saw is that Democrats felt they had 60 votes in the Senate. They felt it was easier to make sure that the Democrats were all on one side than trying to reach out to Republicans and losing votes.
For the record, no
Democratic
Republican
side.
ever offered the amendment you're talking about.
Absolutely.
They
Absolutely.
could have done that.
And I wish
or
they
had. Could have gone for Wyden-Bennett. I mean, I don't think the Democrats would have wanted to do the thing you're saying.
Right. It was never on the table.
I'm somewhat more sympathetic, and we should say bringing Medicaid into the exchanges would raise costs quite a lot.
Yeah.
So you have a payment problem there, and that's one reason nobody ever talks about doing it, because nobody knows how to pay for it. But to your point, I think a lot of Republican or conservative healthcare wonks would have loved to do that. The Republicans on Wyden-Bennett always said they didn't really support it, right? They'd always say, look, I'm here because I support the process. I'm not ready to sign on the dotted line for the bill. Maybe they like the bring in Medicaid side. But while I take your point on this, I think you a little bit overestimate, given the record of nobody actually saying, if you do this, I will support the bill. Yeah. To some degree, if Republicans ever could have split Democrats along that choice, they should have. Right? That would have been an interesting split to cause in the Democratic Party. But they did not do that because I don't think they support that.
I wish they had, and I think you're right that Republicans bear a lot of the responsibility for the state of, and I've written this many, many times, Republicans bear a lot of responsibility for the state of our healthcare system because when they've been in power, they haven't advanced with a sufficient energy and priority constructive solutions along these lines. Having said that, I mean, the point is, where I disagree with the Affordable Care Act is not so much with the exchanges. As you said, it's really more about technical adjustments and a few things around the structure of community rating, the benefit mandates, et cetera. I think exchanges are an excellent vehicle, particularly with the subsidies, for addressing the uninsured and for addressing the insured population as well. And what I love to do, and this is, again, what I've advocated very consistently, is if we took those exchanges and we migrated everyone else into them, so the employer-sponsored group, the Medicare group, the Medicaid group, then to me, that's the solution, and we can still get there without repealing the law. So, I look at it as two ways. One, we could, as conservatives, we could have done it by repealing the law and replaced it with a system that was like that, or since we can't repeal the law, taking the law and making changes to the exchanges and migrating people. So I actually would say that I strongly believe that it can be done either way, and I actually think there are a lot of advantages to not repealing the law and making the changes that I
What's
suggested.
so funny about this, and I take, and this is why you like the Swiss system, and because I kind of agree with a lot of it, it's why I do too, right? Particularly, I'm a little bit less sure about Medicare because I think Medicare actually works pretty well. But Medicaid, I think it would be better if we were paying more to get these folks better insurance.
Yeah.
The problem is we'd have to pay a lot more, and particularly in the employer market. One of my issues with the bill as composed is that the exchanges should be open to large employers now. It won't be that way until 2017. I would have liked to see it national exchange. Look, I'm a big believer in centralizing it, but basically what you're talking about is Obamacare Plus or Obamacare Plus Plus, and it's a funny thing here because all that has, everything we're talking about here, it has its own rate shock problems. I mean, I think I'm correct to assume you would like to really get rid of the employer deduction for insurance. You would like to see that moved into a standard deduction or refundable credit or something so everybody gets the same whether you're employed or not. That would create issues for folks in the employer markets. It just, I do, because I think this is a worthwhile point to be clear on, all of this stuff is on some level technical, not a technical, all this stuff is a trade-off. Right? If you want young people to pay a little bit less, you often have to make old people pay a little bit more. If you want the subsidies to be lower, you get slightly lower taxes on the rich. And more generally, if you want the insurance itself to be cheaper, you are dealing with insurance that is manifestly going to make people pay more. Right? Basically, the more you're paying for your insurance on the front end, the more folks are going to or the more folks are likely to have to pay out of pocket.
I agree with some of those points and
Yeah.
disagree with some. So on the point of paying more if the actuarial value is lower, if you pair it with a health savings account and people can save for their own coverage over time or their own needs over time, that rolls over. Right? When you pay a premium, it goes into the vapor. The insurance company gets the money. Right? But if that money is going in a health savings account and you happen to be healthy this year and healthy the next year and then sick in year 3, all that money that you saved in your health savings account covers all of your out-of-pocket expenses. So that accumulation of savings is actually a very powerful thing, and that's why the Singaporean system has been so successful and so cost-effective.
But wait one second on that, because in this bill you have the 80 and 85%. I feel so bad for people who are still watching this. The 80 to 85% medical loss ratio.
Yeah.
So an insurer, particularly an individual market, who doesn't spend, and I'm forgetting which one is in which market, but let's say 80%.
It's a higher medical loss ratio for larger groups, lower
Right, so I think it's
smaller
80%
groups.
in the individual market. So an insurer doesn't spend 80% on actual healthcare, not administration, not profit, has to rebate that money. So it isn't just all going into the ether. Now maybe you think, as a conservative, that we should not have these insurers with all their administrative costs and their profits, and you'd find a lot of friends on the left for that view. But aside from that, I mean, a lot of this money isn't going to either. I would argue that on the HSA, the health savings accounts argument, you can make an argument that maybe people spend less because of a higher level of cost sensitivity, because of structure. I could buy into that. There's also issues of what care they decide not to get. But broadly,
there are technical fixes to that.
There are
too.
technical fixes maybe to that, but broadly, I think that we should just be clear that like this money isn't disappearing.
Right.
This money, I mean, if the actual amount that people are spending goes down, one of the interesting things about the ACA is so too will the amount that the insurers charge in premiums. I was speaking to somebody who heads a very large insurer, who's off the record, so I can't say who they were, but he was semi-lauding and semi-complaining that now they're taking all the art out of setting premiums, because after the first year, it's just going to become very mechanistic because they have to spend at least 80% on actual healthcare costs. They're not going to have a lot of discretion on how to price. They can't just price at what they think the market will bear. They will have to price basically at 80% plus or cost above that. And so I think it will be much more in the sort of structure you talk about there with the HSAs, where you're seeing a real drive towards true cost.
So a couple of points I would make. You've characterized a lot of these issues, these technical tweaks that we've talked about as trade-offs. If you tweak it one way or the other, there's an equal amount of winning and losing.
And I should say, not everything is like that.
Yeah.
I don't mean to
so what I'm trying to argue is just that there are certain designs of insurance products that are more cost efficient, that provide coverage to people so that they don't go bankrupt from their medical bills, but also cost the least amount in terms of premiums because they're actuarially the most efficient products. There are ways to structure the insurance market in terms of how you do the things like the community rating, guaranteed issue, et cetera, that minimize adverse selection, because the more adverse selection you have, the more expensive insurance is for people who need it. So my goal is to make sure that we're very sensitive to how to minimize adverse selection and how to have the most efficient insurance product. Because we have the most efficient insurance product, it's cheap. And a cheap insurance product in terms of cost is one that everyone will buy because it's a good deal for a healthy person as well as for a sick person. And that's why I think the Singaporean model is instructive, because there they have universal coverage. They spend 1/7 of what we do in terms of national health expenditures, 1/4 of what the Europeans do. Now, I'm not saying that we can.
But let's
we
say
can
what
port-
Singapore does, right? I mean, and I'm very interested in the Singaporean system. They set all the prices
Yep.
that hospitals can
Sure.
charge. They set all the prices that doctors can charge.
Sure.
So everything you're doing, essentially, the government has negotiated for on the front end. They have an individual mandate, we can call it, to save 20% of your wages.
Sure.
Essentially, 20% of your wages are directly garnished into a savings account.
as
It
opposed
is
to just going to the government and
Right,
being
sure.
spent by whoever.
But I do think, although some of that also happens because you pay your premium separately, and
Yeah.
those insurers are essentially government organs at that point.
Yeah.
So the Singaporean system I would consider a huge improvement on what we have, but
too.
it is a level of command and control that not only is beyond what I think anybody here can take, but is beyond what anybody in this discussion has even considered talking about.
In no way do I
mean,
want to
I actually think that might be unconstitutional.
In no way do I want to suggest that the Singaporean system is the right model for reform in the U.S. in terms of we can't just take their plan or the system and replicate it here. But I think it's economically instructive. It's economically instructive that they've managed to cover everyone with high deductible or with catastrophic coverage and health savings accounts. I'm not saying we can do exactly what they do, but just the fact that they've done it and been successful with it, and that they're a wealthy country, high GDP per capita, life expectancy is higher than ours, that they've done all that at 1/7 the cost should be instructive to us. That should show us that, to your point about trade-offs, there are ways to actually cover everyone, guaranteed issue, make sure everyone gets coverage, no one's bankrupt, but at a lot
Yeah.
lower cost. So that's my focus.
But one thing I think it's worth saying here, and I think we need to end this at some point, because I don't imagine anybody's left out there. If you are, let me know. But in these systems, right, because when you're talking about a 7th, Singapore is very cheap, Great
Yeah.
Britain is very cheap. Compared
Yeah.
to us, Canada's cheap, Sweden's cheap,
Sure.
France is cheap, everybody's cheap. And what all of them do, the thing that they all do, is not health savings accounts, right? That is not the common denominator. The thing every single one of those systems do is the government is a primary negotiator. The government
price.
says, how much can a drug company charge? The government says, how much will a doctor's visit cost? The government says, how much a hip replacement will cost. And the per unit price of healthcare in those countries is way, 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 way down.
Right.
And if I were to say, what are we not doing? The one thing we think will probably work on costs that we're not doing, it's that. But that's where you do get a kind of a trade-off there on potentially the innovation side, because there's a reasonable argument that a lot of the world is free riding on the amount we pay for everything. But
Yeah.
putting that argument a little bit to the side, I actually think that's a very different sort of set of considerations than what you're talking about here. I mean, the kind of numbers you're talking about, nobody thinks we would be paying a 7th for our healthcare if we moved to HSAs across the system. And more broadly, the kind of things we're talking
But
about
will
in the
we be
exchanges.
paying less? Probably.
But more broadly, the kinds of things we're talking about in the exchanges are a little bit more of a trade-off, right? The age rating thing is a little bit more of a trade-off. Obviously, if you get it way wrong in one direction or another, you have very, very negative sum results. But what you're talking about of 3-to-1 versus 5-to-1 or 10-to-1 or keeping it in an age range, you're talking about folks who are older paying a bit more, folks who are younger paying a bit less. And whether you think that's a good thing or not, that is a trade-off, and the same thing goes on the benefit design. If you talk about bringing the actuarial value down to 55%, and you talk about having a $10,000 deductible, and you talk about it not having to cover large classes of care, you're talking about a kind of trade-off. And one of the trade-offs you make is that people will think they have something covered, and then they don't, or they won't actually be able to afford the out-of-pocket maximum they're dealing with. I mean, some of the problems we have now. And I just think it's worth being more honest about, or not more honest, but honest about these trade-offs, right? One thing that I think has been a frustration for me in the rate shock discussion, it's a reasonable point to bring up, and it's an important one, because we do need to get it right with these young adults. On the other hand, we also need to say what would actually be happening in another system, or what are the ways to fix it, and how much of it would they fix, and what would happen if we tried to fix it that way. And I do think there's been a little bit too little talk of, okay, well, how much more do we think older folks should have to pay? How much more do we think sicker folks should have to pay when they're older? And how much more do we think that insurance should make the individual pay than it currently is?
Yeah.
I think it's worth being, and I think you've been pretty specific on this, but I think in general it's something that there's I think implicitly in all these discussions, some magical healthcare plan out there that has no trade-off anywhere.
Yeah.
That's not the world we live in.
No, you're right. There's always trade-offs. And let me address both of the concerns you've raised. So on the issue of price controls, I think the best approach is competition among providers. So it's ideal if you have multiple hospitals or you have a telemedicine medical tourism that allows you to deal with that. In some cases that can't happen. In some cases you can't, either because one hospital system has vacuumed everyone up or just because of the nature of the particular service. You can't have as much competition. And there I'm more open to the kinds of regulation on price than as a hardcore free market conservative that I might want. In fact, I have a piece coming out in National Review in probably a couple of weeks that addresses this, that says maybe in highly concentrated hospital markets we should look at more government regulated prices, just because in that environment the insurers have very little leverage to negotiate price with the hospital, and the alternative to single payer in that sense is to have a more open, transparent process of price negotiation that starts, say, cartelized the way the Swiss do. And on the point about, let's get the numbers out there so that, say, an alternative plan like mine, the trade-offs are established. So one thing I'm working on this summer is I'm going to do that. I'm going to really flesh out the details of this general framework, which I've written op-eds about, and say, okay, what would the trade-off be in terms of how much more old people would pay or less, how much less young people would pay? What would that do not only to just the average cost of insurance in the system and the exchanges, but also to exchange spending? Because ideally, if I'm right that you can make the insurance market more efficient and less costly, that should lead to less exchange spending without actually leading to less coverage. So these are some of the problems that I'm thinking through and working on, and I'll certainly be sure to flag that white paper when it comes out.
I look forward to seeing it.
I'm sure you'll love to read it.
Avik, thank you very much. Thank you for
pleasure.
you who sat through it.